Okay, excellent. All right, thanks everyone. Rajan Shukla, CEO of BrightStar Therapeutics, and I'm joined by my Chief Medical Officer, Dr. Joe Tarver. We'll be performing a tissue demo on a new type of corneal allograft known as BrightMEM. So today we're going to go through a little bit about BrightStar Therapeutics, touch on the scientific background, walk over some clinical data, then go through the procedure. Now, BrightStar was established in 2021 from in-licensed technology, developed by Dr. Josh Ho, with me as well as our Chief Scientific Officer here at University of Minnesota. And we soft launched this product in April of 2023 after raising a Series A round earlier that year. We developed a new treatment, which is BrightMEM. This is a decellularized Decimase membrane allograft. It has special proliferative proteins, which is able to create a new foundation for the ocular surface, enabling the support of limbal epithelial stem cells. This can enable ongoing epithelial regeneration and is a treatment for patients with impaired corneal healing. This includes limbal stem cell deficiency and persistent corneal epithelial defects and affects around 265,000 patients per year. So the way this works and why a decellularized Decimase membrane allograft is able to help impaired corneal healing is because it contains special proliferative proteins such as spark-beam40 and vitronectin. These proteins are found in the limbal niche, but not in central cornea, and are essential for the maintenance of the stemness and proliferative potential of limbal epithelial stem cells. We first walked through some preclinical studies and we studied the culturing limbal epithelial stem cells on amniotic membrane versus Decimase membrane and saw that it was non-inferior to grow on Decimase membrane and also trending more consistent. We also looked at this in a few additional models as well and demonstrated non-inferior performance to culturing limbal epithelial stem cells on these allografts. And you can see for contrast, when we grow limbal epithelial stem cells on BrightMEM, but then allow it to grow off of that membrane onto other substrates, that we lose expression of ABCG2 and P63 alpha. So these green and pink cells here are indicating the presence of limbal epithelial stem cells. The blue stain is a nuclear counter stain showing that we lose that expression. And we're mostly looking at mature, differentiated epithelial cells that have lost their proliferative potential. So in a normal cornea, you'll see stratified layers of epithelium, where the bottom layer during a wound heal may express some P63 alpha, but notably you won't see ABCG2, which is a limbal stem cell marker. But then when we grow those same cells onto BrightMEM, we see that the cells touching the bottom layer of BrightMEM, after the cells stratify into normal corneal epithelial layers, the cells touching the membrane on the bottom layer maintain their stem cell phenotype. So maintaining this, essentially we're maintaining a reservoir, gives us the ability to maintain a reservoir of epithelial stem cells on the ocular surface, and this is what can enable ongoing epithelial regeneration for patients with impaired corneal healing. Now, in order for this to benefit patients, the membrane, when transplanted to the eye, has to be able to persist. So we showed in multiple laboratory models that the graft is stable and resistant to degradation. This is a model which shows amniotic membrane and our membrane BrightMEM being submerged in collagenase, and the amnion breaks down very quickly. We see that clinically as well. You lose it in a few days to weeks, but the BrightMEM will persist in this model beyond 24 hours. And we also showed in a stromal degradation model, we protected two mate corneas, one with amniotic membrane, one with BrightMEM. We soaked a Wexel sponge in collagenase, which is an enzyme that dissolves collagen. We placed them both on top. We placed both of them on top of the amniotic membrane and also the BrightMEM protected corneas, and we showed significantly less thinning in the BrightMEM protected cornea versus the amniotic membrane protected cornea. So we soft launched this product in April of 2023. To date, we performed 72 BMAX or BrightMEM anterior keratoplasty transplants. 100% of reported cases have reepithelialized. We've also observed a marked reduction in pain after use of this graft, which is something that we didn't anticipate during our preclinical studies. Oh, I also mentioned that we showed the resistance to degradation and durability of this graft in preclinical models. Now, more importantly, we showed this clinically. Our very first BrightMEM patient was an 80-year-old with limbal stem cell deficiency secondary to trabeculectomy after treatment with mitomycin C. This patient underwent an amniotic membrane transplant as well as an auto-slet, failed both of those treatments within 5 months. This patient did not want a KLL due to the risk of the immune suppression, and there was limited healthy limbus in the contralateral eye, and so clow also was not an option. This patient consented to try a BrightMEM, and you can see in this image, this is post-op month 3. We have a nice clear cornea. We see a little bit of neovascularization in the periphery here, but this dead stops right at the graft margin. And this patient is now 18 months post-op and it has remained stable with a clear cornea. So now I'll welcome Joe to come, our Chief Medical Officer, and talk through a few more cases as well.
Thank you, Raj. I'm Dr. Tauber, but I'm actually not that Dr. Tauber. There is another one. He's also a corneal surgeon, and this is one of his patients that was very influential in his interest in doing these procedures. This particular patient was treated with Tivdak, a new chemotherapy, one of the ADC drugs that has very severe keratopathy. And this patient had bilateral disease, terrible photophobia, disabling, was not willing to continue taking the chemotherapy. That was the only thing keeping her alive because of the degree of keratopathy. So that's her level of suffering. Head wrapped in towels, absolutely miserable. Dr. Tauber called me and said, I really don't know what to do. And I said, I think you ought to try the BrightMEM. I think you're gonna find it's a good platform for regrowing epithelial cells, and hopefully you can get this to heal. He's done the procedure on both eyes. Patient was pain-free within 7 days. I think it was within 2 days. Recovered acuity of 2600, 2500. She's very ill with other diseases, but no infection, and absolutely a wonderful result. He's done 12 procedures. This is sort of his first experience with the first 6, and they're really kind of remarkable. Pain has not been an issue in any of the patients post-operatively, and we see quite a few patients with a marked improvement of vision, 20/80, 20/70, 20/40. When you do procedures early, you pick and choose who you want to do them in. The procedure is really designed for patients with limbal stem cell deficiency, and I don't mean 100% deficiency. We think the sweet spot is probably 25 to 75% limbal stem cell loss. So this works better if you still have some limbal stem cell population to recover the surface. Patients who have 0 stem cells need stem cells. They need a different procedure. This is a platform for those cells to grow on and to repopulate the surface. But his results in patients with the first 2 are the Tivdak toxicity, non-healing ulcers, corneal scarring, herpetic non-healing. Every patient has healed. You can see time to healing is 45 days or less, and his experience has been excellent, and he's done many, many more. We're not seeing any added risks from doing this procedure, but remember, we're talking about patients with a non-healing ulcer. So they have risks anyway. They have risk of superinfection. Things can happen. We've seen absolutely nothing added. Neovascularization has been variable. We've had some patients who neovascularization seems to stop. Stromal melt is a theoretical risk. We've not seen that at all. Superinfection has happened, but outside of the area of the graft. Again, these are high-risk patients with chronic surface disease. We had one patient whose graft folded over, which we're phrasing as graft dislocation. But by and large, this is a fabulous procedure at a moment when you really will feel like, I don't have anything else to do for this patient. These are the most severe ocular surface disease patients that this is going to come up for. So again, let me go some practical details. Because this is considered minimally modified corneal tissue, this is not an investigational procedure, this is approved tissue. This is covered by all carriers. As Raj said, to date we've done 72 procedures in kind of a soft launch. I think that's 18 surgeons. Everyone has gotten reimbursed. And it may not seem intuitive about, so what is this procedure? But you're taking corneal tissue and you're putting it on a patient's cornea. That's a lamellar keratoplasty, which is why we're calling this BMAC, BrightMEM anterior keratoplasty. You might think of calling it an onlay for reimbursement purposes. You're far better calling it a lamellar keratoplasty because that's what they're going to be reimbursing that on. And again, 100% success in surgeons getting reimbursed to date. Tissue is handled as a pass-through just as any other corneal tissue, and at least at the moment it's priced the same as DMEC tissue. It's quite similar to DMEC. We're talking about Decimase membrane, in this case acellular versus Descemet's membrane with endothelial cells. But again, at the moment, it's priced the same. That's all we have as far as slides. The rest of what we're going to do is to show you what this is like to do. Now, we've done a few of the steps ahead of time just to save a little bit of time, but this is really quite close to real time. And I'll kind of explain what we've done before and what you would be doing if you're doing this yourself in the operating room. The procedures are about 15 minutes long in duration to do the whole procedure. They're done under topical anesthetic. It's absolutely a painless procedure. Just to say it in words first, is because they're different pathologies. You need to establish a bare surface that you're going to put the membrane on. So you may call it a scraping, you may call it a superficial keratectomy. You're removing pannus, irregular epithelium, scar, whatever you need to. I don't have a patient here. I have a whole globe here. It still has some not terribly healthy epithelium, so I'm going to scrape that away, which is the analogy to your doing a superficial keratectomy. Good. Please tell me if I drift away, because my centration and your view may not align, so just either wave or scream. So I think for our purposes here, it's going to be, I want to get a little more pressure. I'm not sure for our purposes how important it'll be for me to keep this well pressurized or even to do a full superficial keratectomy, but you want to do a full superficial keratectomy to the point where you can leave a 0.5 millimeter margin on all sides of the graft. If epithelium grows in and grows under the BrightMEM, BrightMEM is probably not going to adhere long term. It may fold, it may fully displace. So you need to put it down on a clean, dry bed that's denuded and dry. Obviously, this whole globe, having sat here for a while, is quite dry, and we don't have it fully pressurized. So in that sense, it won't look fully normal. When you order BrightMEM, it comes to you like any other cornea for any transplant you might do. You take that out, you put it in your trephine. Different pathologies may call for different diameter grafts. A BrightMEM, I'll say you can go up to 8.5, 8.75, maybe 9 millimeters on a good day. Most cases that you'll want to do, I think, are going to be around 8.5, 8. This particular, right, for this demonstration, this is a 7.5, but that's certainly not a limitation. These are prepared like a DMEC, so Descemet's membrane is peeled off, and depending on the skill of the technicians at the eye bank, and these are done at Lions Gift of Sight in Minnesota, they're quite skilled, they can get a pretty good size graft. So 9, I have to ask Josh, I really 9 is possible. 8.5 is 100% safe. So we've trefined the tissue, we've dried our corneal surface. We just pick up the BrightMEM, which has been stained with trypan blue, and it's been marked with an S stamp. And that's really just for surgeon being able to see what they're doing. You place the BrightMEM on the surface, and then you spend the next 1 minute to 2 minutes with Wexel spears drying around the edges of the button just to pull out any fluid that may be sitting there. I should say there are a few other tips and tricks that we've really developed doing a bunch of these. Before any of you do this, I think this is really quite simple. I think if you watch the video that's on our website twice, most of you are going to say, well, I can do that. I think it's worth another 15 to 20 minute conversation with me or Josh. There's a few things we've learned that I think are going to be helpful. So I will say, as we dry around the button, you notice I'm not moving the button. That's intentional. You don't want to displace it. Right now, the endothelial cells, which are still working, are pumping fluid out. This isn't sewn on. This isn't glued on. This is going to stick by itself. So again, after 1 or 2 minutes, 0.12 forceps. I'm going to keep a tying forceps in my left hand because sometimes it doesn't quite behave the way you want it to behave, and it's nice to have another tool ready. What do you know? We have something blue that's left on the surface. Now, hopefully you can see, I like closer to 2 minutes. Josh is 1 minute. I mean, have two surgeons ever done things the same way? That's not in my experience. So that's not round, is it? So there's some little folds, there's some crinkles. It's not, your intuition may make you reach for all sorts of things. What I'm going to say absolutely don't do is take that Wexel sponge and try to drag it. You can probably tear it with a Wexel sponge, although Desmace is actually quite resistant. But it unfolds very easy, as you'll see with BSS. Now sometimes you'll get a fold where the fold goes underneath the tissue. Then I like to use a tying forceps to sort of drag in the opposite direction away from the fold, and it just opens up. We've realized in playing with this in the wet lab, and by the way, in the operating room, now you take more Wexels, do more drying for another 2 minutes, you're done. The one other thing we're recommending is use a little bit of tissue glue. I like to seal, there are other products available. You're not gluing the graft on. What you're doing is tacking those edges down just so that they're really stuck down before any epithelium comes in to get underneath it. So you've placed the graft, you've dried the graft, a little bit of tissue glue, and by little I mean a little, to seal 2 drops of solution 1, 1 drop of solution 2. In the beginning we were using, I think both of us were using 4 drops of solution 1 and a little bit of 2, 1 or 2. That's really too much, because after you let that glue polymerize, we cover with a bandage contact lens. I'm not going to do that now. I'm not going to do the to seal today. But when you put the contact lens on and you've had 4 drops of glue, it comes oozing out. And if you're really unintelligent, you say, well, I'm just going to pull that away. And you can find you can pull the glue away, and you might be looking at the BrightMEM in your hands too. So don't do that. So when I did some 4-drop glue procedures, I like to take some Westcott scissors and just trim off any excess that's extending beyond the contact. That works very elegantly. You'll leave the operating room with the eye as white as when you walked in. This is not a procedure that generates any pain, any inflammation. It's simple, it's elegant, and it works. It's really a very good combination. So you know the steps I've left out. It takes another moment or so to do the trephination. Maybe I shortened a little bit on the drying time, but this is a 15-minute procedure under topical anesthesia. So simple. I've told I've got a lot of corneal colleagues and friends, if you do one, you're going to do 20, because you're going to love this. It's wonderful, and it's wonderful at a moment when you have nothing else to offer patients. So that's all I had for the live presentation, if you will. I think we're just going to take questions. This has to be new for all of you. So if no one has questions, you're not paying attention, because you must have something that you want to ask. We have some surgeons who've done questions that, do you ever pair it with an amniotic membrane? There are people who try all kinds of things, where you can do a BrightMEM, and then amnion, and then a contact, and then a tarsorrhaphy. And if the patient heals, which part got them better? Because I don't. So I'm a purist. I like to know the results of what I'm doing. So I know I'm much more simple. I've never put an amnion on top of a BrightMEM. Josh, have you ever? Josh is the inventor. So Josh, stand up. I want you to get some credit. This is not my science. I just talk nice. So that's why I'm here. No, it's BrightMEM contact lens. My very first case, I mean, I don't want you to think I have good judgment. So I did a severe atopic patient, suspect pemphigoid. And what I didn't pick up on is they really didn't have enough fornix to fit the big contact lens I was using. So I did the case. I'm thinking, this is beautiful. I'm ready to go. I put the contact on. Can't get the contact to fit. So, as a surgeon, you can't leave the operating room until you solve the problem. So I just kind of shoved it in there, and I did a 50% tarsorrhaphy. And I thought, fine, I'll leave this stitch there, temporary tarsorrhaphy. I'll leave this for a while. She came in the next day with a dried up contact lens, folded and halfway sticking out, and a lovely 50% tarsorrhaphy. And I said, okay, that didn't work. What am I going to do? So I took another contact lens and I trimmed it down to 8.5. And I mean Westcott scissors trim. This is not talking about anything elegant here. So with my left hand, I held her lids wide apart. I took out the dried up contact lens. I smiled when I saw the BrightMEM sitting there perfectly adherent. I used the tying forceps, took my new hand-cut contact lens and shoved it in there. Patient did great. Don't do that, okay? Don't do that. It's not a recommendation, but yeah, you can't leave until you've solved it all.
What cases have you had that have not been successful?
Success is in the eye of the beholder, and these are complicated cases.
Absolutely.
So for some patients, the goal, some people, when they hear a new procedure, they will try it on their very worst patients. No vision potential, end-stage glaucoma. We've had some bullous keratopathy patients just with severe pain. It has been totally effective in stopping pain. We have no reports of non-healing. So maybe that's one way to answer. Josh is doing a big clinical trial on limbal stem cell deficiency patients, again, up to 75%. But I can't tell you results now because that's not a 1 month outcome. It's not a 3 month outcome. Let's talk in 6 or 12 or 24 months. So it's too soon to say that. We're looking at NK patients. We're looking at zoster patients who won't heal. I did a severe Salzman's nodule patient with debilitating photophobia. I mean, 18 months, hat pulled down, can't function. 2 days, she's fine. Pain gone, change of life. So you heal fast. I can't tell you why it reduces pain as rapidly as it does, but we've seen it enough times to say that's pretty predictable and reduces photophobia very well too. The one area, again, we don't have enough to say, I don't want you to think this stops neovascularization with 100% certainty. That's been a little variable. Some patients, the vessel will come back in. Some patients, like Josh's, they don't. They come up to the edge of the graft and they stop. So we are still in learning mode with this, but it's very, very exciting, and it's an added tool. This isn't replacing anything. You have nothing that does this right now. This is not a better amniotic membrane. That's not it. Most people use amnion as a blanket. Yes, you can use amnion as a substrate. You really have to sew it down and get it adherent. Maybe some people do it, but it's not that common anymore. This is a substrate. This is a base for cells to grow on. And again, I'm overstating the mechanism. Maybe you're all familiar with the XYZ hypothesis. Stem cells come out of the limbus, they migrate centrally, they move upward, and they differentiate. In my mind, we're changing that to Z only. You have more stem-like cells over the entire corneal surface, and it's an easier path to differentiation just moving up. So I'm stopping practice to do this. I love this. And I've done advanced cornea for 34 years, so changed my mind.
How long do you leave the contact lens on?
It's variable depending on the indication. You'd think you take off the contact as soon as they're healed. Again, it's early, we're a little nervous. We're gonna say 2 weeks at a minimum. We've had people leave it for the whole 45 days until they heal. And loose flat, not tight lens. Somewhere.
Any subepithelial haze or opacity?
The question is any subepithelial haze or opacity? Zero. This is an optically clear membrane. We've seen no immunologic reaction whatsoever. It's immune privileged. We're not expecting it. So use antibiotics postoperatively for sure. Steroids, we say whatever you want to do. But these are not inflamed patients at all.
If epithelium grows underneath, what do you do?
You peel away the membrane when it becomes loose enough that it won't stay. Sorry, I'm not sure if everyone can hear. If epithelium grows underneath the BrightMEM, you're probably going to lose the BrightMEM. Now, but what else do you have? You got epithelium that grew back in, so it's not such a bad day. You solved the problem. I don't know that you can.
But you need to peel off the rest of it because it might be, not complete.
Well, the BrightMEM will not dissolve. Okay, amnion is gone 7 days, 21 days. BrightMEM, I can't say permanent until we follow patient permanent, but Josh has seen him for 18 months.
this really, this is kind of highlights the importance of breeding out at least 0.5 millimeter wider so that we're not laying down on top of the amniotic membrane. We really want to, and then also when you're putting glue on, we're essentially sealing the edges with glue also to kind of prevent the epithelial inlet to regrow on top.
I peeled it off. I had a patient who was folded over almost 75%. Epithelium had grown into the, let's call it bare, the remaining membrane, yes. Which is very, very easy, by the way.
Yeah, I understand that. But
Yeah,
everything.
right, you're not going to leave it there.
Please.
What's the largest you've gone up? Like, what's the largest trepidation you've made?
Josh may have the record. I've gone, I think I did an 875. Have you gone bigger? So 875 is the record. Please go ahead and beat it.
What's the experience been like with NK patients?
What's the question? What's the question is what's the experience with NK patients? What's NK? Yeah, it's a lot more complicated than that, right? Because any chronic surface disease patients loses sensation. So I'm going to struggle with what's really the pathology there. Is it a herpes patient with lost sensation? Is it primary NK? Now people say NK is dry eye. I think that's a very dirty diagnosis. So we think this is a wonderful procedure in NK patients. You don't have to wait 3 to 4 weeks for approval. I should check who's in my audience before I say things like that. Yeah, I mean, you order tissue through your eye bank. It takes as long as getting any other corneal tissue. So, you know, boom, you're ready within the week. So I think NK is a very appropriate diagnosis. We've talked a lot internally about doing a clinical trial, and we got bogged down into, well, what is NK anyway? Very challenging, I think, to define that group of patients in a clean way.
Sorry, I'm asking
No,
you a question.
you're asking good questions, so don't stop.
If you have basically NK with some ulceration and crater, do you fill that crater first with something or just put the membrane on top of it? What's going to happen with that depression?
It's a great question. The question is if you have some cratering or you have an irregular topographic surface and you want to put a BrightMEM on top of that. Well, this isn't going to fix it. It's 15 microns. I don't know that it's flexible enough that it's really going to knuckle down. I think it'll vault a little, but there's nothing to fill underneath.
I think if it's very macro irregularities, it's going to contour to it. Like the micro irregularities, it actually smooths those out a little bit. So actually, I think like I've done like Salzman's nodules or like bad limbal stem cell deficiency, where I'm ripping off like Bowman's and the anterior lamella, and it's a little irregular underneath. And actually, I think my topography is smoother after the BrightMEM because it lays over and it sort of smooths out.
But those are elevated lesions. I'm talking about.
So like divots I haven't done the.
But you know, here's what I think would really happen. I think the BrightMEM will adhere. I think epithelium will grow. And what does epithelium do? It fills divots. So you're going to wind up with a round surface with if you could measure, and you can, epithelial thickness, it's going to be all over. But I think you're going to wind up with a round surface. Tell me how your first one goes.
It depends on the depths of.
Of course. I think you may be waiting a while before you get there. But if you heal with epithelium, epithelium will solve some problems over time.
Or probably the same thing I did with the amniotic membrane. I filled that crater with a multiple layer of amniotic and then on top of it.
And I was going to give you that answer, but amnion melts.
No. Amnion to fill that, the same thing that they do with,
Yeah.
This is in my experience. If I have something similar, I put 2 or 3 layers of amniotic membrane, glue it down, and then put one on the top.
I've certainly done exactly that.
Yeah, those layers become part of the stroma.
But what do you think 2 months later you still have amniotic tissue there? You have something there.
Yes, something there. It's smoothed out and it's covered with the surface membrane dissolved, but the membranes down there become part of the stroma. So I think here also probably we may need to put something there.
So maybe you do a multi-layer BrightMEM, because that's optically clear, and it's permanent. It will not melt.
I can use the rim of this and fill that crater.
Nice. I've said it before. I like how you think.
What's the longest it has stayed unepithelialized?
Everyone has healed. We've seen, I don't know if I have everyone's data, that's why I'm going to hesitate there. Shakar's cases, 45 days. Victor Perez, Victor lives on severe streets, so some of them go longer. All of mine are no more than 4 weeks. So mine are 28 days tops.
In conjunction with like an autograft stem cell or a cadaver keratograft?
We're early in the experience, so far I've done only BrightMEMs with no added stem cell whatsoever. You can certainly think of this as a staged procedure. You're going to do stem cells later, but I think many times we do amnion, hope we get a good result, and if not, well, then we're going to come back with stem cells. Well, now you can come with a far better procedure than amnion, but if you want to do a BrightMEM slet, please do. We have people doing it now. I just don't have results I can share.
Albert Chung has done a Redmond sled. Charles Lane, Stanford has done
Josh, you want a microphone?
has done Summit on top of BrightMEM, and we're still waiting for results. I've done this in some early partial failure of data. Seeing do well at least a month out and stuff. But yeah, one thing I think Joe didn't mention, there's an S-step. I don't know if you can see it.
Yeah.
The rationale behind this is that the fetal layer of desmoid layer actually looks a lot like limbal basement, which is part of the extracellular matrix that supports limbal stem cells. And so what you want is the fetal layer side up. And so there's an orientation mark, there's an S there that helps you orient, make sure, if you're putting it down, it's going to end up right in case you just want to smooth back out. There's an S stem there, and then also post-operatively, that's how we confirm there.
Can you see the ring edge like 2 years out, 18 months out?
You can see this on OCT. I don't think we have OCT 2 years out, but it's elegant on OCT.
But not everyone does.
So if the membrane has, the fetal portion of membrane has the same architecture as the basement membrane.
Not architecture, same collagen makeup and same protein content, growth factor content.
Membrane is also the collagen alpha 1, alpha 2 subtype, which is not what you see in central basement membrane. And then it has internectin and scorpion 40, which are only found in the fungus, and also have been shown ex vivo to support the proliferation of blood cells. So that's what we're
So what happens if you are a little bit too rough on the material? Does that area not expand out and proliferate as well, or does, as the stem cells start to go and grow across, do they start filling in the gap?
So those proteins are bound to the collagen matrix of collagen. So I think mechanical come up. I'm not going to sure.
You can't wipe off the good stuff.
Well, that's what I'm trying to figure out. Like, can
Yeah.
you really do? Basically, you can be relatively rough with this stuff, and you'll be okay.
Which, as a cornea surgeon, it's kind of thrilling.
Yeah, I know.
So, we're looking at a different application method. We're talking about preloading, and there's some nervousness about this is too fragile, we can't do it. So in a wet lab environment, we took the tissue and flipped it over, reversed it from S to reverse S 4 times, and not by surgeons, by non-surgeons with no tear. So it's pretty tough. We know Decimase is tough.
Yeah.
It's just sort of fun to be able to touch it.
I actually
You're not allowed to touch Decimase, right?
I actually like to squeegee out
Fluid. Okay, yeah.
when I put on. Joe laid it out very nicely.
Yeah, you saw an easy one. So BSS can flatten, squeegee action is next. Worst case, like a LASIK flap, float it again.
Yeah.
And it adheres very, very nicely.
That's the tips and tricks section where we tell you more, things that could happen. Why did I hold the tying forceps? Because sometimes when you lift the anterior stroma away, the membrane wants to stick to the stroma and it's not sticking to the surface. So I'll take a tying forceps and just hold down that corner, and that solves that problem.
We are looking at cryopreserving it to see if we can make a shelf-stable version of it. And for that, we need to evaluate mechanical.
And actually, I want Raj to speak about our most exciting things. Why don't you just mention BrightStem?
One quick question. What's the shelf life? Is it exactly the same 2 weeks of
You know, we haven't tested. I mean, I think right now we're thinking 14 days, 2 weeks.
2 weeks.
It's acellular. Could be much longer. We just don't know yet.
Right. And then in pipeline, so this is our first product, which is the decellularized decimated membrane allograft product, BrightMEM. We also have a pipeline product called BrightStem. This is a new version of CLET, which is growing, cultivating limbal epithelial stem cells on a transplant substrate and then transplanting that to the eye. So for these patients that are not treated with BrightMEM alone, that could be above 75% limbal stem cell deficiency to total limbal stem cell deficiency. When we look previously, you see worse long-term outcomes when you look at CLET versus KLAL. And one of the main reasons here is that when you transplant cells with KLAL, you have limbal niche. You have a niche support that maintains that epithelial stem cell population long-term. Now with CLET, when you transplant on a substrate such as a fibrin membrane or an amniotic membrane, once that membrane breaks down, which is in days to weeks, just depending upon the substrate, you no longer have that niche-like support that BrightMEM is providing, and so you get terminal differentiation of those cells. And then we can look at these CLET outcomes and see 6 months we have pretty good visual acuity, and then it's starting to fall off from there. And so think about the life cycle of a mature corneal epithelial cell. So once these cells differentiate, turn over, then you get disease recurrence after that. So the idea with BrightStem is that we now have a niche-like substrate, and we talked about that this will form a construct with a basal layer of limbal epithelial stem cells. We have mature corneal epithelium on top of that, and then if we support those limbal epithelial stem cells long-term, then we potentially have the first long-term version of CLET that can improve those outcomes while being less invasive. And we have a novel method of creating this allograft as well. When you look at the acceptance criteria for CLET that Holoclar established, they saw, on average, 3% limbal epithelial stem cells would perform much better than under 3%. Our method, as we showed here, produces around 80–90% limbal epithelial stem cells based on the method in which we allow them to grow in a single construct. Basically, we're removing stroma cells. We induce cells to grow from the limbus of one donor cornea. This is an allo-CLET onto the ocular surface and grow to confluence, and then that's transplanted. Now, what's also really remarkable about this, when we think about the types of cells that we're going to be transplanting, we have these decimated membrane allograft, BrightMEM, which is acellular, immune privileged. Limbal epithelial stem cells also are going to be immune privileged. So we have way fewer of these cells with that have high immunogenicity, and we are anticipating that this will not require immune suppression, systemic immune suppression, and will require topical only. So this is right now in preclinical studies, and we'll continue to give updates on that as this progresses.
Just so it's perfectly clear, you'd be ordering tissue with a BrightMEM and a cell layer. That's a STEMI cell layer, not mature epithelium. So that's pretty exciting, we think. Future.
Testing in rat models.
Do many patients get recurrent erosions after they've healed their epithelium?
I don't think we have any report of a recurrent erosion on top of a BrightMEM yet. We've had some optometrists pull them off by accident. It goes in the don't do this category again, but no, it's been 72, that's not a big number. The results are wonderful.